Hi, the purpose of this video is to demonstrate the examination of the pulmonary system. Here I have a 25-year-old who denies any cough, any problems with sputum, shortness of breath, denies any problems with asthma, bronchitis, or any infectious disease such as tuberculosis. He denies any environmental exposure at work or home to any toxins or asbestosis or dust, and he denies any trauma to the chest. He also does not smoke. Past medical history is at age 18. What started as an upper respiratory infection was diagnosed as a right lower lobe pneumonia. The first part of our examination will be inspection and palpation. Usually the patient would be undressed for this examination, but for the purposes of this video, my patient is going to leave his shirt on. You want to observe the anterior chest and posterior chest, looking for any masses, any abnormalities. You want to see if the chest is symmetrical. You want to make sure the patient doesn't have a barrel chest. You're looking at the color of his chest, the color of his skin, for any superficial venous patterns, and the prominence of the ribs. So you would inspect the back and then the front of his chest. Then you want to palpate the chest. With your hands, you want to feel his thoracic muscles. You want to feel his back, looking for any tenderness, bulges, depressions, masses, and movement. When you're doing a pulmonary examination, you want to be familiar with the anatomical landmarks. Can you put your head back a little bit? Here we have the trachea. You want to inspect it and make sure it's midline and not deviated. Okay, you can put your head down. Right underneath the trachea is the substernal notch. That's right below. And then the angle of Lewis is also called the sternal angle. It's at the second intercostal. And if you just walk your fingers down on the sternal notch, down a few centimeters until you feel a bony ridge, that's the angle of Lewis. The costal angle is down here. It's where the left and right costal margins meet to form an angle. The back of the neck, the cervical spine, C7 is back here, and then right below C7 is T1, the start of the thoracic spine. When you're doing the pulmonary examination, you want to assess the patient's respiratory rate. In an adult, it should be 12 to 20 breaths a minute. You would look at his rate, hopefully with him not seeing that you're watching him, and you would count to get the respiratory rate. You would observe for any shortness of breath, any labored breathing, and the use of any accessory muscles. Also, you would be listening for any audible sounds such as wheezing or stridor. These are sounds that you could hear without using your stethoscope, and they could indicate a narrowing of the airway such as asthma. The next part of the examination is the thoracic expansion. You stand behind your patient and you place your thumbs at the level of the 10th rib. If you can scoot forward just for a second. And you put both your hands like this at the 10th rib, hands on the back. And you watch your hands, take a deep breath in and out. You watch your hands and thumbs move. And you watch your thumbs diverge. And this should be symmetry when the patient is breathing. Okay. Next, you want to feel for crepitus. Crepitus is actually air that's under the subcutaneous tissue. It almost feels like Rice Krispies. So you would palpate and you would listen and feel if you hear any crackling sound. That would be air that's trapped under the skin. The next part of an examination would be for tactile fremitus. You can use your palm or hands, or you can use the ulnar part of your hands, and you place it on your patient's back. You have the patient say 99, 99. As you move your hands down the back, there should be symmetry with the vibration that you hear the 99. If it's decreased, this could indicate excess air in the lungs, such as emphysema or effusions. Can you say 99?
99, 99, 99, 99, 99.
Okay, very good. Next, we're going to percuss and auscultate the lungs. With percussion, I'm going to have you put your head forward a little bit and fold your arms. And I'm going to take my finger and I'm going to tap it to hear for resonance. You go down one side and go down the other side. Resonance is the expected sound. If it's dullness or flatness, that suggests a pneumonia, pleural effusions, a pneumothorax, atelectasis, or asthma. So that is percussing. I'm hitting my middle digit, quickly tapping. Okay, very good. Next is the measurement of the diaphragmatic excursion. This is where you ask the patient to take a deep breath and to hold it. And then you percuss along the scapular line until you locate the lower border where the resonant changes to dullness, and you mark that point. So take a deep breath and hold. Okay, so right about here is where I hear dullness. If I had a marker or tape, I would mark it. You can breathe. Now you ask the patient to take some breaths, and then on exhalation, hold it. So take a couple deep breaths and then exhale and hold. You can start percussing above the marked spot, and again, when the sound goes to dull, you would mark that spot. You would do it on each side, and this would be when the resonance changes to dullness. The excursion is usually 3 to 5 centimeters. You can breathe. All right, next we're going to auscultate the lungs. We can auscultate anterior and posterior. We're listening for normal breath sounds, and we're looking to see if we hear any abnormal breath sounds. Can you take a deep breath for me? In and out every time my stethoscope touches you. Okay, very good. Can you put your arms like this? I want to listen to your lateral chest. Take a deep breath. You would have the patient put their arms like that, and then you would take your stethoscope and listen to the lateral chest. Okay. Again, I could repeat this on the anterior side of the chest. Again, going back and forth, listening for the breath sounds. I would be looking for anything abnormal, such as wheezing, bronchi, crackles, or a friction rub. That would be abnormal breath sounds. And then the next test we do is for vocal resonance. Vocal sounds travel through the lung field, may be heard with a stethoscope. We're going to ask the patient to count numbers or say the alphabet. Normal, the sound should be muffled and indistinct. So can you start saying the alphabet?
A, B, C, D, E, F, G, H, I, J.
All right. And the sound is muffled and indistinct. And that concludes our examination of the pulmonary system. Thank you.